the previous talks in the series, and I'm honored to participate. I'm going to be presenting a case of dorsal wrist pain and its ultrasound examination. I have no disclosures. The case is a 50-year-old male. He's had dorsal wrist pain for 6 months. He doesn't recall any preceding trauma. He's complaining of pain with wrist extension and load bearing. He hasn't noticed any swelling or masses or asymmetry, and his history is otherwise really nonspecific. The other talks in the series have emphasized this, and I think it's worth re-emphasizing the importance of reviewing previous imaging. X-rays complement ultrasound very nicely, and especially when looking at the dorsal wrist, the bony structures can serve as landmarks for navigating the soft tissue components of the wrist. So it's really worth getting to know the bony anatomy of the wrist, as that'll help you sort out where you are when you're looking at the soft tissue structures that we'll be discussing. This is my dorsal wrist exam protocol. It's only 13 images, so it's very manageable. I think it's really important to have a structured protocol when you're working through a problem. This will add organization to your study. I'd even recommend we have our protocols programmed into the ultrasound machine, and this will kind of guide you through as you work through an anatomic area, and it'll keep you from trying to depend on your memory to capture all of the relevant images. I divide my protocol for the dorsal wrist up into 2 parts. First, we'll look at the wrist joints through the dorsal area, and then the second part is the dorsal extensor compartments. Now, our first image is a long axis view of the wrist. I like to get it in this plane where we can see the radius, the lunate, and the capitate all coming together and kind of cupping each other. Pay special attention to these recessions between the bones and the hypoechoic areas that come out of them. These are called the dorsal synovial recesses, and these are folds of synovial tissue that come out of the wrist joint and can serve as windows into the joint and give you clues about what's going on in the intra-articular wrist. There are 2 of these dorsal synovial recesses. This is the proximal dorsal synovial recess here, this hypoechoic area coming right up over the lunate. The second is the midcarpal recess, or the distal synovial recess, and this has a different configuration. It hugs tightly right up against the capitate here, and it has a flatter appearance. Now, here we are on our very first image of the protocol, and right away we're seeing an abnormality. We've got this anechoic structure right here. This is not the distal dorsal synovial recess. It's not the radiocarpal recess. So right away you're super excited, and it's easy to get carried away and just start snapping dozens of pictures of this thing in every direction. But I would encourage you to stay disciplined, stay structured, and go about evaluating this in a methodical way. So we will need to take additional images, and these are just kind of standard ultrasound ways of looking at things, but Doppler imaging is essential in dorsal wrist masses. Vascular malformations are common bumps in the dorsal wrist. Doppler will also light up on synovitis, so we need to have Doppler imaging. Compression is very important, so this is pressing down with the transducer over the bump in the wrist and seeing if you can squish it. That will help differentiate between ganglion cysts and wrist effusions. Anytime we look at something on ultrasound and we're scrutinizing it, you want to look at it in multiple and ideally perpendicular planes. So this is no different. take measurements of what you're looking at. That is useful information to include in your report. And then finally, just a detailed description of the anatomic location of your lesion. Where does it start? Where does it go? What is its course? What are the adjacent anatomic features? The cine clips are very useful here. They can provide fine detail when really scrutinizing the anatomic extent of your lesion. Now, with the additional images that we've looked at, we should be able to sort out what this bump, cyst, lesion is in the dorsal wrist. And there are three common things that we want to distinguish between. The ganglion cysts, synovitis, and joint effusions are some of the most common. So ganglion cysts are well circumscribed. You can see they have a fairly clear border here. It's going to be anechoic. You'll commonly see posterior acoustic enhancement, which is a brighter white line on the deep surface of the cyst. These can be multilocular. Ours isn't. Ours would be considered a simple cyst. Ganglion cysts are not compressible, and that surprises patients. They will think that it's bone because it feels so firm, but ganglion cysts are filled with a thick mucinous fluid that doesn't compress, and that is a distinguishing feature to differentiate ganglion cysts from joint effusions. Another unique feature of the ganglion cyst is that they are relatively narrow. So when you're looking at them in the short axis, they will not span the full width of the capitate. These have been described as tubular, which makes sense to me because they have a narrow kind of tube-like shape, and that's as opposed to the synovitis, or the joint effusions, which occupy these dorsal synovial recesses and have a wider distribution. Ganglion cysts are not vascular, and the most common origin is the scapholunate ligament, its dorsal fibers, or the joint capsule in that area. Now, synovitis is a thickening and hypervascularity of the dorsal synovial recesses. These are not compressible. And again, they have a wider distribution. You'll see that they span the full width of the capitate. One pearl here is to be careful not to bounce the transducer when you're looking at synovitis. You can end up giving yourself a false positive by creating Doppler flow and fake yourself out on the vascular study. Joint effusions also occupy the dorsal synovial recess, but this is just fluid. It's not a thickening of the synovial tissue. So the difference there is that joint effusions are compressible. Again, they have this hemicircumferential spread, so wider than the ganglion cyst would be. And to differentiate joint effusions from synovitis, one thing is that the simple joint effusion will not have vascularity. So by going through our additional images and what we know about common dorsal wrist masses, we can call our cyst, our finding, a ganglion cyst. Now, ganglion cysts have an interesting relationship with some of their surrounding anatomy, and specifically the radiocarpal ligament, which goes from the radius to the triquetrum, and the intercarpal ligament, which spans from the scaphoid to the triquetrum. Now, most ganglion cysts, as we mentioned, arise from the dorsal fibers of the scapholunate joint, but their course from there can be variable. Some cysts will advance forward, as shown in type 4 here, and tuck themselves below the scaphotriquetral ligament, this one, and we're seeing it here, and they'll stay between the intercarpal or scaphotriquetral ligament and the capitate bone, where they are hidden from the naked eye. So these are called occult ganglion cysts. And these can be differentiated from cysts that start out again at the dorsal scapholunate fibers, but then they advance and they emerge in this window between the radial carpal ligament and the intercarpal ligament. Here, they come above, superficial to the intercarpal ligament. They pass the extensor tendons, and they will present themselves as a palpable bump in the dorsal portion of the wrist. Another piece of relevant anatomy here is the location of the posterior interosseous nerve. I thought you could just forget about this nerve after it ducks into the supinator in the elbow, but it turns out that's not true. It comes back into play in the wrist. You'll see it with the fourth dorsal compartment tendons in the dorsal wrist, and some authors have suggested that this nerve, which innervates the dorsal capsule of the wrist, is compressed by ganglion cysts, and that accounts for the pain that some dorsal ganglion cysts cause. That is controversial, and who doesn't like controversy at 7:30 in the morning? So if we're satisfied with our evaluation of the ganglion cyst, we've taken our pictures, we've worked it over as much as we can. Now we can return to our protocol. We want to be thorough and finish the whole thing because sometimes there's multiple findings on exams. So our next view is short axis images of the dorsal wrist, and I would encourage you to think of the wrist as a layered structure here. So as we work through, the most superficial layer would be the extensor retinaculum. Look closely at that. The next layer down are the extensor tendons and the tendon sheaths that surround them. Below that are the extrinsic wrist ligaments that we just mentioned. And then down at the ground floor, you'll see the carpal bones and the intrinsic ligament, the most significant of which is the dorsal scapholunate ligament. The dorsal scapholunate ligament gets special attention in our protocol. It gets its own picture. The scapholunate ligament stabilizes the carpal bones, and ultrasound is really a nice way to evaluate the scapholunate ligament. You can actually see the fibers of the ligament. Sometimes you'll see disruption of these fibers, and with dynamic imaging, you can demonstrate instability in the scapholunate interval. So this can lead you to suspicions of a slack type pattern of arthrosis, which is a cause of dorsal wrist pain. We also look at the distal radial ulnar joint. Arthrosis here is a possibility. And we always obtain Doppler imaging when looking at the distal radial ulnar joint. There this can be a location for early inflammatory disease in a subset of patients. So we're already on to the second phase of our dorsal wrist exam. We're going to work our way through the dorsal extensor compartments now. We typically survey these in a short axis, looking at the detail of the extensor retinaculum, the tendon, the bone, the surrounding structures. And if we see an abnormality, then we would definitely obtain long axis images, Doppler images, dynamic imaging. The first compartment is the abductor pollicis longus and extensor pollicis brevis. This sits below the extensor retinaculum and right above the radial styloid. We can look closely for an osseous ridge here at the radial styloid, and when you see this, it is predictive of a septum that can divide the tendons here, and sometimes they will have separate tendon sheaths. Another piece of variant anatomy in the first compartment is that abductor pollicis longus can have a multilamellar appearance. Can have multiple slips, and you want to be careful not to mistake this for longitudinal split tearing of that tendon. When you look at the first dorsal compartment, you'll notice some surrounding structures. There's a cephalic vein, the radial artery, and then the branches of the superficial radial nerve. Superficial radial nerve can be a causer of dorsal wrist pain. It can be entrapped below the antebrachial fascia more proximally. There can also be neuropathies, and you might see a thickening of these nerves on ultrasound. You also want to be aware of the position of the superficial radial nerves if you're planning to inject the first dorsal compartment or do a first dorsal compartment procedure. And then one trick with looking at the first compartment, you'll kind of notice this is kind of at the apex of the radial wrist. You want to use a lot of coupling gel to get the best images of this compartment, and make sure you're not squishing the cephalic vein. So the second dorsal compartment, extensor carpi radialis longus and brevis, is notorious for causing intersection syndromes with its neighbors. It intersects with the first dorsal compartment proximally and the third dorsal compartment distally. And when scanning the second compartment, you want to look at it in both of those areas and evaluate for the intersection syndromes, as well as looking at the tendons below their retinaculum, just on the radial side of Lister's tubercle of the radius. The third dorsal compartment is extensor pollicis longus, and this sits right up against Lister's tubercle on the ulnar side. And you'll note that there are variant morphologies of Lister's tubercle here. You want to scrutinize the bone carefully, look for projections which might abrade extensor pollicis longus and lead to degenerative tearing. We also suspect that some of these Lister's tubercle morphologies that might be placing EPL at a more exposed superficial position might lead to injury or more wear and tear over time. So there are three members of the fourth dorsal compartment. There's extensor digitorum communis, extensor indicis proprius, and then the posterior interosseous nerve. All these are significant. I like this dissection here because it pulls EPL out to the radial side, extensor digitorum out to the ulnar side, and you can see again the posterior interosseous nerve passing right down the middle of the wrist. This is important to recognize if you're going to be injecting the radiocarpal joint or the midcarpal joint. You want to be sure not to pass the needle through the posterior interosseous nerve. This is a compartment where I think it's important to look at the thickness of the extensor retinaculum and also evaluate the tendons and the tendon sheaths for effusion. Gymnasts can have a problem here. Well, not only gymnasts, anyone that loads their wrist and extension can get a problem called dorsal retinacular impingement, where you might see a thickening of the retinaculum, usually more than 2 millimeters. You're getting interested. You can see tendon changes or effusion, so that's a problem you might find in the fourth dorsal compartment. The fifth dorsal compartment, or extensor digiti minimi, sits right over the distal radial ulnar joint. So it has a close relationship there, and in fact, arthrosis at the distal radial ulnar joint is the most common cause of rupture of extensor digiti minimi. Okay, and lastly, we will take a look at extensor carpi ulnaris in the sixth dorsal compartment. This one is special because it actually has two coverings. So the first covering, the one we've been going through, the retinaculum passes over the ulnar ridge of the ulna and attaches to the pisiform. So this allows for a range of motion with pronation and supination. The deeper covering, this fibrous subsheath, which wraps around ECU, tethers it to the ulnar groove and provides the stability. Now, don't be surprised if you look at extensor carpi ulnaris and you move the wrist through a bunch of range of motion with how much motion you will see. It is normal for extensor carpi ulnaris to shift half of itself out of the ulnar groove when the wrist is supinated, flexed, and ulnar deviated. This is a normal range of motion and should not be mistaken for ECU instability. So with that, we've worked our way through pictures in a structured, complete fashion of the wrist joints and the extensor compartments, and we can talk about our report. So we always lead in with the title of the report, our indication, technical information, and then in the findings paragraph, we always start with noting that we've correlated this with radiographs. The next paragraph is describing the joints. Then we get into the description of our cyst. So I call it a simple cyst as opposed to multiloculated. It's not compressible, it's avascular and anechoic. And then we get into the size and the location where the cyst is located between the capitate and the intercarpal ligament. Lastly, we just mentioned that the dorsal compartments of the wrist are unremarkable, and our conclusion is that this is an occult dorsal ganglion cyst of the right wrist. So that is the report. I think we've got a few minutes for discussion and questions, and I think we can open it up for that.
And that was excellent. Anybody have any questions or comments? I'll just make just a couple comments. One is, you know, there's many ways to do the report, and some people like to have templates for the report and fill in. In this case, you know, Dr. Nelson chose a prose form, but there isn't just one way to do a report as long as all the information is in there and it's complete. The second comment I'll make is, you know, ultrasound has allowed us to see occult dorsal ganglions with a significant amount of frequency, certainly more than MR, especially if there's an arthrogram associated with the wrist MR. And a lot of them can be asymptomatic. So I've found that guiding a 22 gauge needle to the center of the cyst with a limited fenestration and injection, one can be, in many cases, curative if it is the pain generator, or two is, again, it's a diagnostic test to understand whether this is truly the pain generator or there's another etiology to it.
Yeah, thanks, Doug. One of the papers that I read mentioned that before the widespread use of ultrasound, the most common way to identify occult ganglion cyst was on exploratory surgery. So ultrasound has really been a game changer for the identification and treatment of ganglion cysts.
Mm-hmm. There is a question. Are there any characteristics that you could see that would make you more concerned for a giant cell tumor or other more concerning pathology?
Yeah, so I think, you know, evaluating any sort of mass, you're looking at the characteristics. So the type of the border, the character of the cyst or the matrix, the echogenicity pattern, vascularity. And so working through those, again, just systematically and using the information that you can get and describing it as well as you can will help give you most of those clues. And then, you know, kind of putting the pieces together with the images you have. So looking at the borders, the matrix, the vascularity, the compressibility, using all of those studies will help you differentiate. And I don't know if you have more information about specifically about giant cell tumors and how those look.
Yeah, I mean, giant cell tumors can be hypoechoic. Small ones you may or may not see Doppler activity. This would be a very unusual location for a tenosynovial giant cell tumor, but never impossible. And so I think, you know, that's a good point for the person who asked the question, is you're always thinking about a differential diagnosis. And I think, as Ben pointed out here, this has all the characteristics of an occult ganglion cyst. Again, point taken is that you should always in your mind have a differential diagnosis. And I think we all have experiences as we're sure we're seeing a structure that we know the diagnosis and ends up being something different. So that's a good point. Any other comments?
Hey, this is Maderic. Great job, guys. Yeah, I will just chime in too, you know, with the last comment. Sometimes it can be really intimidating to start to look at masses. And I think, you know, just think back to whenever you get MRIs and you look at other reports, you know, as Doug said, sometimes we're not 100% sure on these things. And so, you know, you want to describe it the best that you can. And if there's any features that, you know, in this case, this is clearly a ganglion cyst, right? And so you can be very confident with that. But, you know, if there are other features that make you, you know, not 100% sure, you know, describe it the best you can, put a differential diagnosis in. So, you know, if there were different features, you could say, you know, most likely this, you know, could be consistent with that. And then you may need to recommend other follow-up as well. And so those are just things to think about with masses. You know, when you're not sure, you can recommend other imaging, you can recommend follow-up imaging, and you should get comfortable with providing, you know, somewhat of a differential diagnosis based on the common features. So that's definitely kind of a next level step with a lot of the ultrasound, but it's something to kind of have to get comfortable with, so that you're not, you know, getting too intimidated by some of these masses.
All right, right at 8 o'clock. Again, thank you, Ben, for excellent presentation. As mentioned before, our next case is August 7th, where Troy Henning will be presenting a proximal hamstring case. So have a good Friday and a good weekend, everyone.